Hello everybody, Happy New Year. Last time we saw each other I think was in December. It is a bright new year and I hope everybody's new year is off to a wonderful start. We've been working now on our 32nd town hall today and working to get a little bit away from COVID, but unfortunately COVID keeps not letting us do that, so I'll give you a quick update towards the end, but it's going to be very quick and just update you on a couple of great recruitments we've had for Houston Methodist as well. In the meantime, I want to, as always, thank the Society for Leading Medicine for sponsoring and supporting this, and all of you as supporters in the Society for Leading Medicine. I'd like to welcome our brand new chairs of the Society for Leading Medicine this year. It's Kristen and John Berger and Dr. Waverly and Adam Peaks. They will serve for the next couple of years, and we're just delighted to have them on board. Actually, we met with a couple of them virtually yesterday to plan many of the events and planned the future of this, and so thank you to each of them. You know, it's January, it's the new year, and probably the most common resolution I think people make is to lose weight. And what is it, the 19th? So by about now, most people are realizing it's not working as well as they thought it might. And so today we're actually going to have a great timely topic here, listening to a couple individuals here who are quite expert in this field. First, we're going to hear from clinical dietitian Yolanda Pringle Lancaster, who will be giving us tips on healthy eating and how to maintain a healthy weight and a healthy diet. And then we'll be hearing from Dr. Garth Davis, who is the medical director for the Center for Weight Loss and Bariatric Surgery. We're delighted to have him here as well. As always, if you have any questions, you can text the word DeBakey to 37607. Also excited that we have two people on the live stream today. So if you have questions, they'll be typing away furiously to answer them. We have senior clinical dietitian Bernadette Valdez, and we have senior weight management dietetic weight specialist Winifred Hudis. And both of them, thank you for being there, and thank you for answering everybody's questions along the way. So first, we're going to start with Yolanda. Yolanda, could you give us some tips this year for maintaining our weight?
Absolutely, absolutely. Well, welcome to 2023. Yes, I am a little late. It is the 19th, I do know that. But a lot of you, like Dr. Bloom said, that some of you have already started on making your weight loss goals or trying to focus on your weight management for the weight loss that you lost last year. That navigation can sometimes be really difficult because you are setting up goals that sometimes may not be obtainable. So you want to make sure that we are looking at planning out our goals and then making them be successful. As most of us do know, the obesity rating is rising in the United States, with 41.9% of adults classified as obese. In Texas alone, the range is around 40 to 45. With children, 19.7 are obese. That's 1 out of every 5 children. Rates differ between the racial and ethnic groups. Obesity can also increase your health conditions like heart disease, type 2 diabetes, even some cancers, and can cause poor mental health. When you look at weight loss, a lot of people just look at the weight itself, but weight loss can also help improve other health conditions like improving your well-being, your mental health, diabetes, your blood sugars, insulin resistance, joint pain, short of breath, being able to move up and down stairs. Others can also reduce the number of medications. So maintaining a healthy weight can always improve something other than just the weight itself. When you're making weight loss goals, a lot of people look at it as, I want to lose 50 pounds. Sometimes that might not be realistic. When you look at your weight, consider doing 5 to 10% of your current body weight. I always think gradual weight loss can equal healthy weight. There's been a study done by some experts that found that if you're losing roughly 3% of your current body weight, they've shown that diabetes markers can improve, with 5% for LDL and cholesterol. With some other comorbid conditions, you might actually need to lose more. 5 to 10% might be the best option for you, like a disease like NASH. I know we always try to pay attention to the BMI and trying to get patients below the 25 number. Sometimes that might not be necessary. Really look at it as improving your overall health to achieve that, and then look at the BMI. I like to, I was watching the town hall last time, and I noticed that they mentioned the SMART goals. This is an excellent way to help achieve your overall goals. Make sure that your goals are specific. Know what you're trying to do. Make sure that they are measurable. Like I said, making that idea of 50 pounds is measurable because you're looking at the weight on the scale, but actually look at it as, okay, I want to lose this weight at this time. So make sure that it is attainable. Like I said, 50 pounds and you're trying to lose it by the summer, that might not be realistic. Again, we kind of recommend that patients lose a pound a week, so 50 pounds by the summertime, that's in a little over 20 weeks. Doesn't seem attainable, and it's not healthy. Make sure that your goals are relevant to you. I know we, as dietitians, we make goals for our patients, but if you don't feel like that's relevant to you, talk to us, and we can sometimes work in the middle. Make sure that your goals are time-bound. Saying that you just want to lose 50 pounds in thin air, could it be in a year, 2 years? Could it be in a half a year? Make sure that you're looking at, I want to lose 5% of my weight at this time period, and I'm going to be doing this. When you're setting your goals, make sure that you set them up in smaller targets. They don't always need to be, I want to lose it throughout the whole year. Consider a month. Consider even a couple weeks, saying, okay, I'm going to consider eating at home for 3 days out of the whole entire week. If you're a person who goes out, that actually is a good target goal, because eating at home has definitely shown that it can help with not eating excessive calories. Set goals that are beyond your pounds on the scale. So like I said earlier, eating at home is a good example of that. Sometimes considering less knee pain, being able to walk upstairs, those are things that can be obtained, but they don't always have to be the number on the scale. Consider a goal of physical activity, 150 minutes of moderate intense physical activity, and consider also adding strength training at least 2 days out of the week. Now, I like to use the behavior change model when you're trying to make these goals. Long-term goals, the behavioral changes with obesity can require attention, and it's not something that just goes away. It's definitely shown that even if you have high-quality, short-term goals, if you're not having anything behind it that help you improve the intervention in a long-term scale, its success is really poor. When you're looking at maintaining weight, consider counseling strategies, following up with a dietitian, setting up goals of checking in with yourself to make sure that you are reaching. Like you see, the behavior change model is a staircase. Sometimes you might need to take steps back to actually achieve your overall goal and to maintain your goal. Strength satisfaction comes with outcomes, so making sure that you are working out and getting that physical activity in. Relapse prevention training. Now, it's shown that sometimes you might fall back to old behaviors. Setting up cues to keep yourself in check. So I usually set weight not in a single number, but actually in a range. So if you notice that you're stepping outside that range, either going down or up, get someone involved. Check in with your support group. Having things set up like, okay, I've noticed that I'm starting to gain weight more than I usually am. Maybe I need to increase my physical activity, or I've decreased my physical activity. Maybe I'm going out more than I normally do. Maybe I should consider staying at home. Those are ways to set yourself up. Cognitive reconstructing. Sometimes we kind of want to demonize ourselves for kind of not making the goals that we are setting for ourselves. Don't do that. We are allowed to make mistakes. We are human. But actually setting up goals that help you obtain what you need is the best option. Make sure that you're setting up flexibility. Sometimes we might falter and being able to, or things might happen in our life that can change. We need to set up, okay, I might not be able to go and work out. COVID did happen. A lot of people weren't able to go to gyms. So some people considered working out at home, finding ways. Reflect on deeper motivations. What is the reason why you're losing weight? Or what are the reasons why you want to maintain the weight that you're at? Have those goals set in mind so that if you ever have those times where you're like, oh, I can't do this, or you're able to step back and say, I'm not doing this for the weight. I'm doing this to be able to run a marathon, or I'm doing this to get my A1C numbers down. Those are things that can help and prolong your maintaining of your weight. And again, manage expectations. Again, like I said, sometimes you might not be able to attain your goals within the time period. If you lost 7% out of that 10, you did a good job. Don't demonize yourself for taking only that 7%, because you did get past 5. Make sure that you escalate the treatment when you feel like it's needed. Come see a dietitian, go speak to your doctor. Those are ways that you can help whenever you feel like you're not reaching that goal, or you feel like you're hindering yourself. Tips to help support your weight loss. Keep a food diary. A food diary isn't meant to just track everything and to, when you notice that you've stepped out, kind of demonize yourself for it. It's just making sure that, I'm noticing I'm not increasing enough vegetables in my diet or enough fruit. That helps you see, where am I missing out? Where do I need to include more meals? If you're feeling hungry in between meals and you're noticing that you're not eating enough, that can help. Make sure that you measure your food and eat on smaller plates. Portion sizes in the United States have definitely gone up, and so sometimes we feel like we're eating what we're supposed to be, but actually you might be eating more. I like to believe in yourself. A lot of people kind of want to say that they can't do it or they need that support from someone else, but you can look into yourself and say, I can do this. I can meet my goals. Consider leaving high-calorie snacks off your grocery list. One of my friends, who actually is a dietitian, owns an ice cream shop. I like ice cream. I choose not to buy it. I mean, we are from Texas, so Bluebell is great, but she makes her ice cream from scratch every day. So whenever I want that, I go to her shop. Make sure that you're adding extra fruits and vegetables to your diet, and consider doing a meal prep. I was looking online, and sometimes the meal preps can be $70 for 6 portions. But if I go out to eat, I'm spending $35 on myself. So that's 2 meals alone. You're actually saving money by doing that meal prep. And sometimes adding an extra frozen vegetables to that can definitely help. So a lot of people know this. It's the My Plate method. It's very common. We learn it in school. We share it here in the hospital. But I feel like it's something that we also need to focus on, making sure that you're paying attention to what is on your plate. Making sure that half of your plate is at least fruits and vegetables, making sure that half of the grains you're consuming are whole grains, making sure that you're also getting adequate amount of protein. Protein does not mean that it always has to come from an animal. There are several other types of proteins that you can get, like eggs and beans and lentils. Those are other sources of protein that you can consume that can actually be beneficial. Water. Water is so important. A lot of people leave that off their My Plate because it says dairy, but it's blue as well. Always consider having water on your plate, next to your plate when you're eating. And again, it is my plate, so I take that personally. It's my plate. Everybody's different, so their plates are going to look different. Everyone's at different stages in their life. They might need more fruits and vegetables than others, or even sometimes more protein than others. So again, don't judge someone's plate because it's not yours. Like I said earlier, hydration is very, very important. 20% of your fluids come from food. So even though you feel like you're not getting enough, if you're consuming fresh fruits and vegetables, you actually might be getting fluids from that as well. Drink water in between and with your meal. I always keep hydration next to me, like a jug, because sometimes you're moving so fast. We're a very fast-paced society, especially here in Houston, where we might not always have a water station near us. So keeping a water bottle with you and drinking between meals can definitely help you reach your hydration goals. If you're a person who's not the biggest fan of drinking just plain water, consider calorie-free enhancers like infused waters, or for those who can tolerate it, carbonated seltzer waters. Those are really good to drink, and they can definitely hydrate you. Depending on your sex and age, sometimes you might need to consider how much water you need. But on average, women need to consume roughly 2 to 7 liters, while men 3 to 7. Again, depending on your health and your chronic conditions, you might need to consume less water or more. Pregnant women and breastfeeding women should possibly drink more water. Those who have some kidney diseases might need to decrease. If you're having infection, definitely increase your water consumption. So it depends on where you're at in your life. The water scale can change up or down. I feel like this is really important. I stress this with my patients. Reading the food label. One of the most important things on the food label is reading the serving sizes. A lot of people skip this. They look at what the contents are actually having and they're saying, oh, this has this, this, and this, I can eat this. But if you're actually looking at the serving sizes, you're seeing, well, a bag of food might actually, you need to consume a smaller amount to meet those calories or the sugar content or the fat content. The type of fat is more important than the total fat. You want to make sure that you're not consuming trans fat, but you're paying attention to the saturated fat as well. You want to make sure that you're consuming less than 10% of your overall fat intake. Added sugars are also now included on the food label, which I think is a great thing because everyone always wants to look at the total sugars. Well, some foods have natural sugars. So the added sugars is what the company themselves are adding to the food item. And you want to make sure that you are decreasing that and consuming less than 10%. For sodium, Americans consume roughly 34 milligrams on average per day in sodium. You want to aim for less than 23 milligrams. And number 4, paying attention to the percents on the side. The percents on the sides are based on a 2,000 calorie diet. So if you're not consuming 2,000 calories, consider doing some math and plugging it in and realize the percentages might go up for you or down. The label reading, like the nutrition facts, you want to make sure you're reading what is on the food. Are you consuming something that has labeled have salt in the very first letter or the first word, or is it the second? If that's the case, then you might be high in salt or it could be high in fat. So definitely make sure that you are paying attention. And I'm going to say something that's very controversial for a lot of people. Organic and non-organic foods contain the same nutrients. Yes, organic foods do have less synthetic pesticides and fertilizers. Their animals usually have less hormones in them and antibiotics, but nutrient for nutrient, they are the same. Food labels claims can be sometimes confusing and misleading. We always see these words like natural and clean and whole and multigrain. Well, the marketing team of these products are very good. They give them in bright green, orange lights. You want to make sure that you're actually reading the label to see what is in it. That's really important. When you're dining out, make sure you consider if you're ordering something large, consider boxing up half of it. Sometimes out of sight, out of mind can be really good for some people. Look at things that say grilled or broiled. That's also really helpful. Making sure that you're making dinner and not overeating. Select foods that are from the My Plate method. That can really help. Balancing your diet without breaking the bank. Again, we're in an economy where the inflation is high, so you want to make sure that you are considering less expensive foods, you're buying from the grocery stores, and sometimes maybe not getting organic all the time. Grocery store tips, making sure that you are looking at fresh, frozen, and yes, sometimes even canned. As long as you're looking at low sodium, no salt added, that's definitely really important. Frozen vegetables are great, frozen fruits are great, but always look to see what is actually added to those items. Grains, avoid prepackaged single-serving grains because sometimes they can have higher amounts of additives added to it. Popcorn is a great item for a grain. Make sure that you're looking for whole grain breads when you are picking out for the first ingredient. Proteins, sometimes buying the value size is really important. Then you can break it up and put it in the freezer and do smaller batches. Eggs are a good source of protein, and they're sometimes even lower costing. Beans, using canned tuna, those are things that you can swap out. For dairy products, look for low fat, fat-free, and sometimes a generic bread instead of going for these high-end name brand items. Buying yogurts in larger containers and then putting them in smaller serving sizes can be very helpful. Now, as I review from this weight management idea, make sure that we are considering our chronic diseases with obesity. It definitely helps out when you're trying to lose weight and trying to maintain a lower weight with those overall health items. Make sure that you're setting appropriate goals, eating a balanced diet, and regularly exercising. See a dietitian. We're a great resource to help you pinpoint your goals because this is a long journey. It is not a short pace 100-meter race. I would like to thank you for giving me this opportunity, and I will give this to Dr. Davis.
Thank you, Lana.
Thank you.
That's great information. I talk a lot about diet and exercise, and in fact, my wife's always, when we're going out to dinner, like, please don't be that guy tonight. And start schooling people on what to eat. I've written a book on nutrition, and I think lifestyle is unbelievably important. And so people often say to me, if you think that nutrition and lifestyle is so important, why do you cut people open for weight loss? But sometimes, we like to say in surgery, a chance to cut is a chance to cure. And the reason is losing weight is tough. Yolanda went through some very interesting and very important tips, but those tips can still be hard to follow. We know they're right. We know that's what we should do, but sometimes it becomes extremely difficult. And why is it that it becomes difficult? Why do diets fail? This study right here was probably the biggest study done on healthy diets. And you know how diets are. They're almost like religions. Everybody's got, oh, I did this diet and it worked. And someone's like, I did that diet. And in this study, they did a low-fat diet versus a low-carb diet, and everybody lost weight because any diet, any difference to the standard American diet, you're going to lose weight. But eventually, over time, they did exactly the same and they gained back all of their weight. I call this the circle of shame, right? We start a diet, we restrict ourselves, we become deprived, then we start craving. Oh my God, I need that food, then you give in and then you're guilty. You're like, oh my gosh, I've got no willpower and I feel shame, I'm gonna start a diet again. The question is this really a problem of the obesity being a disease, or is this a choice? Are we lazy, or is there something else going on? And I want you to consider the fact that the human DNA and our body structures were formed hundreds of thousands of years ago and evolved in times of feast or famine. And our bodies evolved to protect us from famine. When we go on diets and fasts and things like that, that is an ancient cue to the body to say, wait a second, this is bad, I need to protect them. And when you look at it, it is actually, obesity fits all categories of being a disease. It's chronic, progressive, it's multifactorial, it definitely has a genetic basis, and it's associated with some serious outcomes. And there's many things that lead to obesity. There could be traumas, there could be chronic sleep deprivation, night shifts, but genetic predisposition plays a really big role. And we know that, as Yolanda pointed out, that being overweight isn't just a cosmetic thing. I am not a cosmetic surgeon. We do this because there's serious diseases associated with it. Now let's talk about the genes. They did some interesting studies looking at twins. If you look at monozygotic twins, identical twins, you can see that they have absolutely the same body type. Now, in Holland, they actually had twins separated at birth and growing up in different environments. They still had the exact same body type. In other words, environment didn't affect them at all, only their genes did. Now, you look at dizygotic twins, twins that aren't genetically identical, and you can see they have different body shapes. And so there's definitely a genetic component towards this obesity. And what is this genetic component doing? Like, we think to ourselves, we go on a diet and, someone offers you a cake, you're like, I'm not gonna eat that cake, I'm on a diet. But 3 weeks later, someone offers you a piece of cake, you're like, wow, is that Betty Crocker? That looks good. Okay, I'm gonna take a piece. And next thing you know, you're binge eating on that and you think, I have no willpower, and you start blaming yourself. But guess what? It's not you. There are a lot of hormones in the body that are designed to make you gain weight. In fact, we actually have our fat cells secrete a hormone called leptin. Leptin feeds back to the hunger modulator of the brain. It is almost like the thermostat. And if you go on a diet and you start dropping down leptin, the brain registers that as starvation. And there's multiple other hormones. There's hormones like GLP-1, which has now become medications. The stomach actually secretes a hormone called ghrelin. So the stomach is basically saying to you, feed me, feed me, feed me, almost constantly. There is a difference between people that are normal weight and people that are morbidly obese, that have a body mass index above 40. And there are multiple different things we know, but you have to walk a mile in someone's shoes to understand what they're going through. A lot of times I see people that are thin talking to people that are obese and just say, just do what I do. And it doesn't work like that. If you look at the brain of an obese person, if you look at this this brain scan here, you'll see that where it is red, those are dopamine receptors. And then a person of normal weight, they've got lots of dopamine receptors. But if you look at a person who's morbidly obese, they are lacking dopamine receptors, and their brain looks exactly like a cocaine addict or an alcoholic. And what does that mean? Without those dopamine receptors, they don't get satisfied as easily with a meal. So why does weight loss surgery work when diets don't? There's many reasons. When we do a weight loss surgery, we're making the stomach smaller, so you can't eat as much. We're also changing hormones. People don't seem to realize this, but a big part of weight loss surgery is to change the hormones and to affect these hormones that are written into our DNA to make us eat and to make us preserve fat. It helps you break the weight gain cycle, improves overall quality of life and health. And really, you hear a lot of stuff on the media, but long-term weight control with weight loss surgery is really pretty astounding. We get about 90% of our patients keep at least 50% of their excess weight off, which means if someone's 300 pounds and they should weigh 200 pounds, they're keeping off at least 50 pounds for many years, 10, 15 years. What happens if we take lifestyle? We say lifestyle is important. And it is. Surgery is just a tool. I say this over and over again. It's just a tool. But to say, well, people should just diet and exercise and that's it, they actually did a randomized control trial of this. They took a bunch of people that were overweight and they randomized them at Cleveland Clinic to either really strong medical and lifestyle treatment or weight loss surgery. And you could see in this, no matter what you're looking at, whether you're looking at A1C levels for diabetes or whether you're looking at body mass index, and you can see here that the group that does the medical versus the group that does the surgery, there's just an enormous difference here. So surgery definitely gives people a huge benefit. The Swedish obesity study has actually studied people for 30 years now. And once again, this was not randomized, but they followed people that either went to a medical weight management program or they went for weight loss surgery. And what was interesting in this study was they followed them 30 years, and people say to me, what if I die from surgery? Well, the risk of dying from surgery is so low, but the risk of dying from not getting surgery is actually much higher. And what they found is as time goes on, the people that had surgery actually had an extension of their lifespan compared to a control group. If you look at it, weight loss surgery affects multiple different disease processes. We know that we get a huge drop in sleep apnea, we get a huge drop in hypertension. In about 80% of patients undergoing a gastric bypass, they actually get a cure of their diabetes where they're no longer on any medications. And so weight loss surgery seems to help the whole patient, not just their weight. So who can get weight loss surgery? We use something called a body mass index. So you could look up body mass index calculators online and put your numbers in. It's a measure of your height to weight ratio. Morbidly obese is considered a body mass index above 40 or above 35 with comorbid illnesses, meaning illnesses that are caused by obesity. Now, recently, these numbers have been lowered by the American Society of Bariatric Surgery. They've noticed that people actually, if you're diabetic and your BMI is 30, you should probably get weight loss surgery. But insurance companies haven't quite come around to that yet. We really don't like people to be smoking. You have to commit to going into our comprehensive weight management program. And people with Crohn's disease and cirrhosis have kind of relative contraindications to surgery. I'll just briefly go over the surgeries, but if you're interested in surgery, you really need to meet with a doctor to go in detail. Two main surgeries that are done for weight loss are the sleeve gastrectomy. With the sleeve gastrectomy, we evolved a big, gigantic stomach so that we could eat a lot when there was food around, because often there wasn't food around. And all we are doing is removing that part of the stomach so you're not as hungry, because that secretes the ghrelin hormone that makes you hungry, and you get full a lot easier. The gastric bypass is a little different. We're cutting out a small piece of the stomach, creating a pouch and bringing up a piece of intestine, thereby bypassing the pancreas. This surgery is used more for people with severe reflux because we're bypassing the stomach and all its acid. For people that are super overweight, with a body mass index above 50, and for people with diabetes because we're bypassing the pancreas. We don't do the lap band anymore. If you have a lap band, we could revise it to one of the other surgeries. This was a band placed around the stomach to try to limit the flow of food into the stomach, and it really was not too successful, so that's been abandoned. And now there's a newer surgery called the duodenal switch, or the single anastomosis duodenal switch, which works on not just limiting how much you eat, but how much you absorb. And this is really more for people that have super morbid obesity. The process for approval is to get insurance approval. We do that here at Methodist. We go through your insurance. We find out how much you need to do to get approved. Everybody has to meet with our dietitian. Everybody has to meet with our psychologist. You have to understand that surgery is only a tool and that obesity has many factors, and we need to treat as many of those factors as possible. We have a very comprehensive program here at Methodist. We really treat this as a group therapy. We have support groups, we have dietitians, we have behavioral therapists and exercise therapists with multiple different classes. And at our Center for Weight Loss and Bariatric Surgery, we also do medical weight loss. So if you felt that surgery was not appropriate, we do use the latest medications, we use very low calorie diets, and we use very good lifestyle measures to help you out. So we're always available at the Center for Weight Loss and Bariatric Surgery.
Well, thank you very much, Dr. Davis, Yolanda. Were both very, very interesting presentations. Lots of questions came in ahead of time. As you can imagine, it's a important topic for everybody. So I'm going to start with some more general ones with you and probably both of you, and then we'll move on to some of the surgical questions as well. Okay, so we talked about this a little bit at the beginning because I keep reading articles, I keep hearing people talking about it. We didn't really cover it in either case. Intermittent fasting is kind of the one I hear the most, but there's some tweaks to that as well and some different ways that works. So could you give me a little information on that and tell us all about intermittent fasting?
Absolutely. So intermittent fasting is what they're calling it now, isn't actually intermittent fasting. It's more of a time restricted type of diet. So we were looking at it as not eating, and you're only eating between 8 to 10 hours, when on average most Americans eat between 14.5. So that's what they're doing. And it really isn't always restricting the calorie intake or anything, they're just restricting that time. With intermittent fasting, you're actually skipping days. So you can eat one day, kind of averaging normal, and then the next day you're consuming less than 40%. So if you're consuming a 2,000 calorie diet, you're eating roughly around 500 calories or less. And then the next day you'll kind of go on to that. With the time restricted diet, the research is saying that there could be some weight loss. They find that there is some changes in people with diabetes and different issues like that. But I always want to be cautious, especially with those with diabetes, because you have to watch your blood sugar levels. You don't want it to bottom out or tank, so you want to make sure that you are checking that and you are reaching out with your doctor, letting them know that you are making that change. With actual intermittent fasting, they definitely have shown that there has been significant weight changes, and actually your appetite does change because you're, first of all, not eating for so long and you're kind of skipping that time, so you're allowing that to happen. So there is research leaning more towards actual intermittent fasting diet rather than doing the time restricted diet. Again, those with diabetes definitely need to be cautious on these type of diets because they are allowing themselves to not have carbohydrates, so their blood sugars are going down. So I guess the first thing is, it seems to me when I read about it, everybody uses the word intermittent fasting, but they really mean it's time restricted. Yeah, it's time restricted.
I always hear about is don't eat all night, or don't eat all, for a long period and just eat a bunch during the day.
There's different intermittent fastings that are being studied. There's the 8 hour, where you're eating over an 8 hour or 6 hour window. So most people don't skip breakfast and then they just eat in the afternoon. There's some people that are doing the alternate day, like 5 days a week they eat normal, 2 days a week they fast under 500 calories. These have all been studied. From an actual weight loss perspective, it doesn't seem to be much difference than just doing calorie restriction.
Yeah.
Certain people it works for. They just say, I don't want to eat breakfast, and it works. But if you're eating more for lunch than you would have, it counteracts it. I will say, and Yolanda touched on this, there's something about circadian rhythms in eating. And we know that from the circadian rhythm studies that eating at night is actually really harmful. And so I don't like the intermittent fasting where you're stacking the calories at night. We do know, I say this to my patients all the time, eat breakfast like a king, lunch like a prince, and dinner like a pauper. So we should be shifting our calories earlier in the day because that's when we burn them better. And there is some good evidence towards that.
Yeah. The hours are kind of like you said, 12 to 8 is probably not the hours that you want to do your time restricted. You actually want to do it like upwards in the 9 to 5 period. And they definitely have shown like mood has changed for those who do lean towards the earlier times rather than the later times.
Yeah. And so there's something about the circadian rhythm that really, I would assume that our metabolic rate is running higher during the day and it starts to slow down in the evening. Is that what you're saying?
It is. It does, and it's interesting because we always say a calorie in is a calorie out, and all calories are created equal. Like once you eat a calorie, But we know from these studies that eating the same amount of calories for breakfast versus the same amount of calories for dinner makes a difference when it comes to weight loss. And so the way our bodies are responding, what the hormonal milieu is at the time that you eat, does make a difference.
But you also made a statement that it's not really any different than other restricted. So is it that, or is it that, if I've got the discipline to not eat 14 hours a day, I've just not grazed by my pantry or opened the fridge door and grabbed an extra something?
For some people it works well because they've got the discipline to do that. I worry about it in certain situations. Like I talked about in my talk, there's a difference with someone who has morbid obesity versus someone who doesn't. And someone who has morbid obesity who's struggling, who's battling through that day of not eating because their hunger hormones
they need to hit that dopamine.
They need to get that dopamine. For them, we're creating an eating disorder, and that's a big worry for me. For someone if someone comes to see me and they're like, I love intermittent fasting and it's the one thing that helps, then it's fine. But I would still, even if they like intermittent fasting, I would still like to see them shift it earlier in the day. It's interesting to look at blue zones. So blue zones are parts of the world where people live incredibly long and healthy lives. And a lot of studies looking at what do they do different than us. And lunch is their biggest meal in most of the blue zones, whereas dinner's our biggest meal. We eat big meals before we go to sleep. We don't sleep well, which also contributes to obesity. We get heartburn and all that stuff, and we wonder why.
So talk about sleep and obesity.
Huge.
Talk about that. Is it quantity of sleep, quality of sleep, all of the above?
You know what? It's all of it. It definitely there's a quality of sleep issue. When you're overweight, you could start to get sleep apnea. So we know that sometimes just even a small amount of fat, you'll get it in your larynx area, and it can interrupt your breathing at night. We know that the intermittent breaks in breathing overnight, when your oxygen saturations drop really low, you actually get cortisol secretion. Cortisol secretion is a stress response, but cortisol also does push your body to store fat. We also know from people that are sleeping badly, their hunger goes up quite a bit the next day. And so you know this, if you have a late night studying or a late night anywhere, you tend to eat more the next day. And so sleep is a big contributor to obesity, and it's also a big contributor to some of the diseases that obesity is also contributing to. So we know that obesity contributes to hypertension, so does sleep apnea, and now you've got a double whammy on that. And so these are important things to think about, which is why in losing weight, we don't just talk about food. We talk about, have you had your sleep study? Are you exercising? What are your behavioral habits and things like that? It's a comprehensive treatment.
So for the type A personality out there that wears it as a badge of pride, not sleep apnea, but I just need 5 hours of sleep a night. The people who work really, really hard and do those kinds of things, are they more likely to be obese?
They're more likely. It doesn't mean that every single one of them is going to be. I mean, there are these outperformers. Not all of us are the same. Some of us don't need as much as others. But if you look at studies of night shift workers, sorry for the night shift workers out there, it doesn't look good. Night shift workers have a real problem, even if they're following time-restricted eating. So they did a study looking at time-restricted eating and it flipped. Right. It still doesn't seem to work well because they're totally off on their circadian rhythms. That doesn't mean you're not going to find a night shift worker who's skinny, but if you're looking at the totality of the evidence, it does point towards it being a negative effect.
Interesting. Okay, well, I want to ask you a question, Yolanda. I know some in the audience, this came in from someone in the audience here. As we get older, it does seem like we kind of tend to gain some weight, and it seems like the calories in change for you, or if you don't change your calories in, you still find yourself sort of battling things.
Absolutely.
Talk a little bit about difference of a 30-year-old versus a 65 or 70-year-old.
Absolutely. So as we are getting older, and especially in that 65 range, we're considering retirement. My father retired. He stopped working. He stopped moving about. He stopped walking a lot. So your activity level does shift. So that intake of your normal diet also probably needs to shift. You need to consider probably eating more nutrient-dense foods. I know this time you're like, oh, I can now go to all the restaurants I wanted to because I have all the free time. I don't have to wake up. I don't have to do that. Yes, but consider heart-healthy items. Consider picking items that are, like I said earlier, grilled, that are having more vegetables on the plate. That can help out. And as we're older, our metabolic is a lot higher. So we're able to move, we're burning a lot of energy, so that helps out as we're younger. But as we get older, the metabolic goes down. So we have to start thinking about things like that. Am I telling you that you can't enjoy yourself when you're, like I said, I like ice cream, you can't enjoy yourself going out to your favorite ice cream shop? No, I'm not saying that at all. But you have to kind of start making lifestyle changes as you're making lifestyle changes towards that retirement age as well. You do it financially, why can't you do it nutritionally?
Mm-hmm. So some of it's nutrition, okay, but what about the exercise side for a 70-year-old?
Yeah.
So you got in versus out, right? What do you recommend? I mean, you're 70, maybe, you're not able to do some of the things you did before. What kinds of exercise do you as a dietitian usually recommend in that?
For a lot of us, we consider water aerobics. There are less stress on the body when you're in the water. Start considering doing resisted bands rather than actually lifting weights. Because again, if you're going to become a 7-year-old weightlifter, power to you. But that's not always necessary. We still need to get that physical activity inside. If you are wanting to pick up a new hobby and you have a garden, consider gardening. Picking up those pots, picking up that dirt, moving things around, that's still burning energy.
Yeah.
Staying slightly active. My husband's grandfather, he played doubles still, he's 83 years old. He's staying physically active. You don't have to play doubles, but you can still consider making a hobby that's slightly more physically active rather than being stationary and picking a hobby that's sitting on the couch and watching your favorite show.
Great. Good advice. Well, coupled along with that, we had a question embedded in here about muscle versus fat or versus other places.
Yeah.
Talk about the role of kind of strength training, not necessarily bodybuilding, but just strength training and weight.
Yeah, it's interesting because we do body fat analysis on our patients. I get a report on each patient. How much muscle do they have? How much fat? And a lot of times the issue we're dealing with is not just over fat, it's under muscled. We have a real problem in America with sarcopenia, which is a lack of muscle. The less muscle you have, the lower your metabolic rate. The lower your metabolic rate, the more what you eat is going to lead to making you overweight. We've seen problems with metabolic rate in interesting scenarios, not just as you get older, but also people that yo-yo diet. So we're talking about dieting. A lot of people crash diet. Remember that show, The Biggest Loser? Those people lost an amazing amount of weight. They were crash dieting, working out like crazy, and Johns Hopkins studied them. And what happened is their metabolism dropped like crazy during that show. Interestingly, they followed them up 10 years later. They've gained back most of their weight, and their metabolism is still slow. The metabolism never came back. The body likes to conserve energy really well. If you make it work and you're building muscle, it has to expend. But if you are sitting around not doing anything like Yolanda was talking about, as you get older and you retire and you're no longer moving, your body will save that energy. It will save it for what it thinks is going to be a rainy day, which isn't coming, hopefully not, where we're in starvation. So I think building muscle is very important. There's been a lot of studies recently on resistance training for preventing Alzheimer's disease, for improving your heart. We know that with aging, one of the biggest problems is frailty, the inability to get up, the inability to move. Most deaths in elderly people come after falls. But if you're building up muscle, we know that people that exercise do resistance training have less falls. As far as weight loss, exercise does not do it disappoints people. They think they're going to go and work out really hard. You go for a good weight training session, you burn 400, 500 calories. If you then turn around and have a double cheeseburger, it's over. So we're still playing a calories in, calories out game. But over time, if you resist this training, and that keeps you over time moving more, and that keeps you over time with a higher metabolism, over time you will slowly but steadily either maintain or lose weight.
Is there a better time of day for exercise?
No, that's been looked at quite a bit, and you just got to do what's
it's just a matter of doing it and burning the calories.
Yeah,
and getting
people always like, what's the best exercise? The exercise you will do. Is the best exercise.
No one
get it done.
agree.
Yeah,
right. Well, okay. Well, good. A couple questions have come in over the internet as well. I want to make sure I get to those, specifically around bariatric surgery. One is about what are the risks. You've touched lightly on that, but for somebody considering bariatric surgery, talk about the risks.
Yeah,
and
there's always a risk-benefits ratio. I mean, I don't think that everybody needs surgery, and I don't think that that everybody is going to do great with it. So we do have to sit down with the patient and go through it. There are risks. When we're cutting on the stomach and we're removing part of the stomach, we use staples. The staple could come undone, which could cause an abscess or a leak. Very rare, but it could happen. You could get a blood clot. We use blood thinners. We have all these processes to prevent that, but it could happen. It is a surgery. It could affect your heart and your lungs. We do preoperative screening so that we know that you're safe for surgery, but you could have an issue with that. Could have vitamin deficiency issues if you're not taking the vitamins. You can get weight regain. It's not perfect. You need to participate in the lifestyle components of it. The individual surgeries have individual risks, like a sleeve gastrectomy could lead to reflux and heartburn. Gastric bypass could lead to ulcers. So there is kind of a list of risks. When we sit down with a patient, it's always discussing those risks versus the benefits you would get from the surgery, which almost always the benefits outweigh the risks. And nowadays, the surgery is extremely safe. The risk of dying is almost unheard of at this point, but extremely low.
Well, so you actually segued into one of those questions in there, which is also then somebody who says, okay, I had a sleeve gastrectomy before.
Right.
I've been gaining weight.
Right.
Is it something that gets redone sometimes?
Okay, so if you've had a sleeve gastrectomy and you're regaining weight, and the sleeve is normal looking, I kind of touched on some of the hormones that control obesity. Not everybody is obese for the same reason, and some of them might be a restriction pattern that works on the vagus nerve, that you just need a tighter, smaller stomach. For some people, it might be a certain hormone. When I look at someone who's got a sleeve and they're gaining weight, first of all, what's the lifestyle? Are you doing everything right? Because if you're not doing everything right, then we need to work on lifestyle first. Second of all, are you hungry? I mean, if you are really hungry, we're missing a hormone here. That hormone typically is GLP-1. So I can give you a shot. There are new shots now called Ozempic, also trade name Wegovy for weight loss, that helps a lot with people's sleeve that are gaining weight. Because with a gastric bypass, we increase this hormone called GLP-1. With the sleeve, we don't as much. So we can increase that, interestingly, with eating plants, but also with a medicine. And some people, that's adequate. Some people, they need a bypass after that, so that they could get that GLP-1 effect. With sleeve patients, I've now kind of tended towards doing a duodenal switch surgery I mentioned, where I'm plugging the sleeve in lower in the intestine so they don't absorb all the food they eat, so they're getting multiple kind of things that could help them lose weight, because you don't want a third chance at this. But those are the kind of things we would sit down and discuss if you've had a sleeve before. What could be some lifestyle changes we can make that would fix it? Is medicine appropriate, or would you want to do surgery, and if so, which one?
So, okay, so that you opened that door that was asked earlier, because it's advertised all over now, and it's kind of all the rage. Ozempic.
Yeah.
When do you consider, not now, let's go out of the range of maybe some of, you're debating surgery or, recovery from surgery who's been gaining.
Yeah.
But now, I mean, everybody and their dog wants Ozempic now.
Everybody
so how do you
wants, I've got like a stack of Ozempic. I'm thinking about going on the black market. I mean, Ozempic is a hot topic right now. It's a kind of a weird thing to watch someone use it, because a lot of people, they give themselves a shot and it's just like, oh my God, this is what I have been searching for. All of a sudden, I'm not like constantly thinking about food. This is affecting the brain, like I was showing on those diagrams. And it's pretty dramatic. The problem with Ozempic, it's being given out like crazy without any lifestyle. So they're giving out Ozempic to just, anybody comes in, here's your Ozempic, go for it. And they do lose weight. The question is, how long are they going to lose weight for? Is it going to stay off? Ozempic is expensive. You have to get insurance approval for it. We know from the trials that brought us Ozempic, in the step 3 trial, what they did is they gave everybody Ozempic. 3 years in, they started giving one group placebo. What happened with the placebo group? The weight came right back on. What we know from Ozempic right now is that you're going to have to take it for life. So that's a huge requirement. It's a huge cost. I think if it's done in a program where we're teaching lifestyle, and the Ozempic gives you an opportunity to break bad habits and learn new lifestyles, it may be that you'll be able to come off of the Ozempic. But the way it's being given right now, it's just being given to everybody, and I don't think that's appropriate. It also really, we have a shortage of Ozempic. So it needs to be used in diabetics, and it needs to be people who really need this, morbidly obese patient. I don't think someone with a body mass index of 28 who's going to Cancun for spring break needs to be on Ozempic. It really is a medicine to treat a disorder, and right now the criteria is you should have a BMI above 30 in order to get.
Well, so which really raises one piece of advice I would make for everybody, which is, whether it's bariatric surgery, whether it's weight loss, whether it's weight loss drugs, I mean, it matters who you go to. And you want to be thinking about doing these things in the context of a well-planned, well-thought out, multidisciplinary expertise, dietitians, surgeons, internists, others who are doing this, rather than just the pop into a 2-minute doc in the box to get your prescription for something.
You can get it online now, which is sad.
So unfortunately, sometimes a common problem for us to see those kinds of things. Well, I'm going to ask one last question then. What's a healthy weight for people? How do they decide that? And, would you rather have somebody with a BMI, of 30 or 35 who's like really active and exercising, or somebody who's kind of 24 and, sits on a couch all day? So
that is a golden question. Oh my gosh. Are you asking me for the lottery numbers?
I am asking that. Yes, I would take that, except I think it's back down to
you a curveball.
I know. Well, that actually depends. It depends on a lot of things. Your age, your sex, what is your life looking at? If we're talking about someone who's a little bit older, do I need you to be a perfect, some people say a perfect BMI of 22 or 23? No. What's the purpose of that? What is your health condition? That is what I think about when someone asks me what's the weight, what should I be at? Because we get this question for our patients a lot. Well, what's your health like? Is your A1C under control? How's your blood pressure? Are you taking medications? Like some medications are needed due to chronic diseases from genetics or other issues, but are the issues that can be changed from diet and exercise or getting bariatric surgery, can those be controlled? If that is at your weight where it's stabilized and it's fine, I'm not going to complain. I will honestly tell my patients, you're fine right now. Now, if there's an issue where you're having health conditions and you are out of breath going up a flight of stairs, you're having knee problems, that is where I'm sorry, you're not at the weight you need to be. That is where we're having the conversation of possible weight loss. If you've talked to me and you're having issues with weight loss and you're not able to do it, then I'm like, well, maybe you might need to see your doctor. You might need a referral to see a bariatric surgeon. That is where it needs to lead at. So if there's a number out there, is there a BMI out there? I can't honestly give you one.
Yeah, I mean, like bodybuilders, they have a BMI of
really high one.
Yeah,
absolutely.
Because there's so much muscle, their weight is, and then you could get someone who's got a normal BMI but no muscle on their body.
Absolutely, I do have a bodybuilder friend. He was track and field, and he's humongous.
Yeah,
but he eats. I can see his food diary, and it's almost perfect.
Right.
But he decides he wants to be a muscle builder. So, yeah,
great.
Absolutely correct.
That's great. Well, and of course, obviously the science around this all continues to evolve. It's a field of medicine that's very hard to study oftentimes, when you get into sort of population-based metrics and things. Well, thank you both for fascinating talk. I know very, very meaningful and fact-filled for everybody who's watching here, and me included. So really appreciate everything both you do to help our patients. And of course, if any of you have a desire to see someone here, that can always easily be arranged. So, well, I'm going to wrap up real quick. As I said, we did have a little of a COVID surge. I was talking about last time I was here that it was coming, and I think we're over the hump, which is also some good news here. But I wanted to show you those data and then just brag about a couple of really great recruits to Houston Methodist. So this is a chart you've seen many times. This is our testing. So the blue is how many tests are positive a day, and the orange is the positivity rate. So you can indeed see we've had a pretty substantial increase. You can also see about a week or so ago we started to break and see that come down. We're seeing that in the wastewater as well. So I think we have currently at least peaked. And I say currently because there's a couple variants out there that if they really started revving up, it's possible we'd sort of see a little camel hump kind of deal. But I do think we're probably in the same sort of pattern we've seen now for a third winter, which is, post-holidays, cold weather, kind of surging and then peaking sometime in mid-January and starting to come down, which I hope means we're going to, again, have a really good spring with COVID way down. This is what it looks like in the hospital, so we've had the same kind of trend line there. The other thing we'd talked about in the last time we were talking, we were still pretty far up, is flu. And it did indeed do what we were hoping it would do, which is what it did in the southern hemisphere, back in our summer, their winter, which is it peaked very rapidly, peaked very steeply, and peaked very early, earliest we've ever seen. But you can see here that line, this is a 5-year trend here. You can see that red line to the right there, how steeply that peaked, how sharp that was, and how far down it is to where it's below what we would normally see this time of year. So crossing our fingers that actually flu season is not fully behind us by any stretch, but we have gotten through the big surge there as well. Then I want to just wrap up and talk about a couple of recruitments. Rob Phillips, who many of you know, our chief physician executive for about 9 years here, retired a couple weeks ago, and we wish him all the best. I've actually seen him a couple times since he retired, and he looks great and having a nice early days in his retirement. Very excited to announce that we have recruited his replacement. She will arrive right at the beginning of April, Dr. Shlomit Shal. Dr. Shal comes to us from University of Massachusetts. She is vitreoretinal surgeon, so she's an ophthalmologist. She's chair of ophthalmology there as well as their chief physician executive, and going to come here and be on our team. She is absolutely amazing. You're going to enjoy incredible energy, incredible vision, and is going to be a great member of the team. And the other big recruit, when you think about the huge departments in an institution like ours, Department of Surgery, Department of Medicine are kind of obviously the two biggest. Dr. Milanakis was recently named as our new chair of medicine. He's going to join us in March. He comes to us from Brown. He's actually from Greece originally, and then came and kind of actually redid all his training here, as oftentimes happens when somebody immigrates. Actually trained and then was on faculty at Mass General, and then ended up at Brown for a number of years as head of their infectious disease division, and he's going to be an amazing add to us as well. So we'll get a chance to hear from them. I will make sure fairly early in these series we get to bring these new experts in to one of these town halls in the future. So with that, I'm going to wrap things up, and let me give you a little information about the future. First off, obviously I want to thank Yolanda Pringle Lancaster and Dr. Davis. I'd like to thank Bernadette Valdez and Winifred Hudis, who were, I'm sure, typing furiously on this. Next month, we're going to talk about two different initiatives, MIGHTY, our Methodist Institute for Technology, Innovation, and Education, and MIRIN, the Methodist Institute for Robotics, Imaging, and Navigation. So it's going to be really cool, state-of-the-art, cutting-edge activity there. We will be doing that on a Tuesday instead of the usual Thursday, February 21st. So really look forward to seeing everybody there for a fascinating topic. Thank you for joining us today, and God bless.